Welcome to the Deep Dive. This is where we take really complex reports, research, all sorts of dense material, and boil it down for you. We bring you the key insights. Today, we're diving deep into something that, well, it touches all of our lives, and it's pretty fundamental to the country's overall well-being, even if we don't always think about it day to day. We're looking at a very specific type of investment and the kind of amazing impacts it has, often unseen impacts, really. Okay, so let's unpack this. The topic is the return on investment in biomedical science, specifically here in the United States. And our sources for this deep dive, well, they're packed. We've got reports, research papers, economic analyses, lots of material.
And they really tell a story about how public money put into this area creates value in, well, sometimes surprising ways.
Yeah, and our mission today is really to pull out the most critical insights. How does this investment actually deliver these substantial returns? We're talking benefits across public health, how long we live, individual longevity, but also the national economy.
So we'll look at what the benefits are, but also, crucially, how we measure them. And that's where it gets surprisingly complex sometimes.
Okay.
The goal is that you, listening, walk away with a really solid understanding of this because it truly is a cornerstone of, well, modern life.
Absolutely. Okay, so to kick things off, let's get into the numbers.
Yeah.
The tangible stuff, the economic impact. I mean, it feels right that investing in science is good, but how does it actually work as an economic stimulus, not just, an expense? What do the reports say about the direct multiplier effects, especially from federal funding like the NIH, the National Institutes of Health?
Yeah, the data really does paint a picture of this as a powerful economic engine. The reports we looked at, particularly from United for Medical Research, or UMR, they consistently show a really significant return on investment for that federal funding, mostly channeled through the NIH, as you said. And it's not just money spent. It's like it's doing double duty. It circulates through the economy, creates additional value. So, for instance, the latest figures for fiscal year 2024, they estimate that for every single dollar the NIH funded in research, it generated about $2.56 in economic activity nationwide.
Wow, 2.56 cents for every dollar.
Yep. And FY 2023 was very similar, about $2.46. So think about that. It's more than doubling the initial input. It creates this kind of cascade effect through the economy.
That's a really impressive multiplier. But, okay, when you say economic activity, what does that actually, what does that look like on the ground for people listening? Is it just money moving between universities, or are we talking real jobs, new companies, actual tax dollars flowing into communities?
Oh, it's absolutely tangible. Yeah, it impacts everyone from, highly specialized researchers down to the person running the local coffee shop near the university.
Right.
The scale is pretty considerable. In FY 2024, the NIH put out over $36.9 billion in extramural research funding. That's money going outside the NIH itself. And that investment, directly and indirectly, supported more than 408,000 jobs across the country.
408,000 jobs.
And these aren't just scientists in white coats, right? It's administrators, lab techs, construction crews, building new labs, suppliers selling equipment, even, the catering for scientific meetings.
Right.
All told, that generated over $94.5 billion in new economic activity in FY24.
$94 billion.
Yeah. And the year before, FY23, very similar numbers. $37.8 billion in funding, supporting about 412,000 jobs and creating almost $93 billion in economic activity. So yeah, when we talk economic activity, we mean a huge contribution to payrolls, to local businesses, to the country's overall economic output. It's really foundational.
And presumably these economic benefits aren't just clustered in places like Boston or the Bay Area, the famous research hubs.
No, that's actually one of the really key takeaways.
It's not just a few cities reaping all the rewards. How spread out is it? Does it really touch every state?
It absolutely does.
Yeah.
That's one of the most remarkable things. The NIH funding reaches all 50 states and D.C. It's not just concentrated in those, traditional powerhouse areas.
Okay.
And this wide distribution isn't just a footnote. It really contributes to regional economic resilience, equity even. It changes the economic fabric. I mean, think about a smaller university in, say, a more rural state.
Right.
Maybe a state not typically known as a biotech hub. They get an NIH grant. Suddenly there are new jobs, maybe supporting the lab, maybe a small spin-out company forms nearby. Or maybe the university uses the funds to upgrade facilities, hires more staff, attracts students. It builds a little local ecosystem. We actually saw specific data on this for the 7 most rural states in the U.S. Even there, NIH funding brings back an average of $2.30 for every dollar invested.
$2.30 even in the most rural states.
Yep. supporting, on average, about 2,300 jobs and generating around $353 million in new economic activity per state in those rural areas.
Wow.
So it's not just abstract economic activity. It's investing in local talent, maybe keeping skilled people in their home states, diversifying economies that might have relied on just one industry before.
Yeah, I can see that.
And, politically, this wide reach also helps. It means the benefits are spread across many different congressional districts, making it feel like a truly national investment.
What's fascinating here, then, is how this public money isn't just creating direct jobs, but it's acting as a foundation, like the bedrock for whole industries, high-value industries.
Exactly.
It feels like without that initial public investment, maybe these sectors wouldn't be nearly as strong. Can you tell us more about how it supports, like, the life sciences and biotech sectors?
Yeah, you've really hit on a core concept there for innovation-driven fields.
Yeah.
NIH funding is absolutely critical for sustaining and advancing the U.S. life sciences, medtech, biopharma industries. It's fundamental to keeping the U.S. competitive globally in these really important areas.
How does that support work exactly, beyond just the grants?
Well, it's multifaceted. It includes, for example, the purchase of all the necessary goods and services for research. That stimulates demand across lots of different industries. I mean, think about all the specialized lab equipment, the chemicals, the software, the skilled technicians needed for something like genomics research. Every purchase supports other businesses.
Right, the supply chain.
Precisely.
Hmm.
And then, very importantly, NIH-funded research often leads to spin-out companies.
Oh, okay.
These are new businesses created specifically to commercialize discoveries made with public funding. Like, think about CRISPR gene editing. A lot of the foundational work was funded by public grants.
Mm-hmm.
That basic science then led to numerous companies forming to apply CRISPR in medicine, agriculture, you name it. And these spinouts, they generate tax revenue, create high-paying jobs, and they often attract other innovation-focused businesses to the area, creating this really dynamic environment.
Got it.
And this all ties back to a basic economic principle. Private companies often underinvest in that really fundamental curiosity-driven research.
Why is that?
Well, because they can't fully capture all the benefits themselves. Basic research discoveries are often so broad, so foundational, it's hard for one company to monopolize them or profit directly in the short term. The knowledge sort of spills over to the whole industry.
Okay, that makes sense.
So public funding is essential to build that deep well of knowledge that industry can then draw on for applied R&D. Without it, that pipeline of new drugs, new devices, new biotech, it would likely slow down considerably. It jeopardizes our long-term competitiveness. So it's really an investment in tomorrow's economy, not just today's jobs.
That's a really powerful connection. Public funding seeding private innovation. Okay, let's shift gears now from the economic side, which is clearly huge, to something maybe even more profound, the impact on our health, our lives. This is where it gets really, really impactful for everyone listening. How has biomedical progress actually made our lives longer and better quality in tangible ways?
Oh, the impact on longevity has been just transformative. I mean, life expectancy in developed countries basically doubled during the 20th century.
Doubled.
Yeah. Now, initially, a lot of that gain was from reducing childhood mortality, things like sanitation, basic vaccines. But in more recent decades, we've seen steady gains across all age groups, including adults. To put it in perspective, average life expectancy now is pushing 80 years in many developed nations. Back in 1850, it was around 45 years.
45 to 80? That's incredible.
It really is. And this massive increase isn't down to one single magic bullet. It's the result of continuous, often quite incremental advances. Things like better diagnostics, new medical devices, improved surgical techniques, and critically, prescription drugs.
Right.
Together, all these things contribute to healthier lifestyles, better prevention, earlier and more accurate diagnoses, and just better treatment when something does go wrong.
Okay.
Now, you sometimes hear that life expectancy only goes up by like 2 or 3 years every decade, which sounds slow compared to, say, how fast tech changes.
Yeah, it does seem slow sometimes. But the cumulative effect over time is massive, and that pace is necessary. Biomedical advances need rigorous testing, long human trials. You can't rush safety.
Sure.
So policymakers really need to appreciate that long-term compounding nature. It's not about instant results. It's about sustained progress built over decades.
That's a really important distinction. It's the long game. Can you give us some more specific, quantifiable examples, though, beyond just the average lifespan, like lives saved from specific diseases, societal gains?
Absolutely. The returns here can be just astronomical. Take R&D focused on neglected diseases. These often hit developing nations hardest, but can pose global threats too. Research shows every dollar spent there yields something like $405 in broader societal and economic gain.
$405 back for every dollar.
Exactly. And that research is projected to save nearly 41 million lives between the years 2000 and 2040. Some sources describe that return as, and I'm quoting here, much, much bigger than it takes to justify spending money on roads or bridges or schools or hospitals. It just puts the value of health in a different category.
That's staggering.
And here's another one, closer to home. Routine childhood vaccinations in the U.S. over the last 30 years or so. These programs, built entirely on biomedical research, have saved an estimated $540 billion in direct medical costs.
$500 billion.
Just in direct costs. And the broader social costs save things like lost work days, long-term disability, that's estimated at $2.7 trillion.
$2.7 trillion.
Yeah. And in human terms, it averted about 508 million cases of illness, prevented 32 million hospitalizations, and saved over 1.1 million lives.
Incredible numbers.
It just hammers home that basic economic point.
Yeah.
It's almost always cheaper to prevent a disease than to treat it. These kinds of investments offer disproportionately high returns, both for health and the economy.
So what this really means for us, for the listener, is that this isn't some abstract scientific endeavor. It's direct interventions changing lives every day.
Exactly.
Could we walk through a few more specific breakthroughs, like how foundational discoveries turned into actual treatments people are getting right now?
Definitely. Let's look at a few key areas. Infectious diseases, for starters. Penicillin's the classic example, right?
Yeah.
Turned bacterial infections from potential death sentences into treatable conditions.
Right. Ancient history, but revolutionary.
But the principle applies today. Think about SARS-CoV-2, the pandemic. The rapid development of mRNA vaccines wasn't magic. No, it was built on decades of prior NIH-funded basic research into mRNA, viruses, the immune system. Scientists weren't starting from scratch. They were leveraging a huge body of existing knowledge. That deep understanding allowed them to pivot and innovate incredibly quickly, giving us tools to, get back to some semblance of normal life. It's a prime example of long-term basic research paying off hugely in a crisis.
Okay, what about other major killers, like heart disease?
Right, cardiovascular disease, CVD, still the leading cause of death. NIH research was absolutely fundamental in discovering the link between cholesterol and heart disease.
That was NIH research.
A huge amount of it, yes. That understanding led to statins, other cholesterol treatments, plus public health campaigns about diet and exercise. And the result, a remarkable 67.6% drop in heart disease deaths between 1969 and 2015. Think of the millions of lives the families kept whole.
67% drop. Wow.
And the work continues. Research is ongoing to improve diagnosis, like understanding how heart disease presents differently in women or finding ways to detect those small vessel blockages that can cause heart attacks but are hard to spot.
And cancer, that's another big one.
Huge. For cancer research, a real watershed moment was figuring out the structure of DNA back in the 50s. Seems abstract, right?
Very.
But that knowledge became the bedrock for all modern gene therapies used in cancer today. It allowed researchers to identify specific mutations, like BRCA1 and BRCA2, linked to breast and ovarian cancer risk.
Which led to targeted screening and prevention.
Exactly. And scientists are doing real innovative things now, like using antibodies from lupus patients to make ovarian cancer cells more vulnerable to treatment. It's very interdisciplinary. A big focus now is also tailoring therapies to individual patients to reduce side effects, improving quality of life during and after treatment, which is so important.
Definitely.
And beyond those, NIH funds work deepening our understanding of incredibly complex neurodegenerative diseases like Alzheimer's and Parkinson's, and a very direct, tangible outcome responding to a crisis, the opioid crisis. NIH research led directly to the development of the naloxone nasal spray.
The overdose reversal drug.
Right. Used by first responders, even bystanders, to save lives on the spot.
Yeah.
Offers people a second chance. So you see this pattern across diseases. Foundational science provides the basis for practical treatments. Basic research is just indispensable for future breakthroughs.
That really paints a clear picture of the human impact. But, you often hear the argument that while these new technologies are great, they're also what's driving up healthcare costs. Can you add some nuance there? How does biomedical investment actually help reduce costs in the long run? It seems counterintuitive to some.
It's a really good question, and it's a complex dynamic. It is true that brand new cutting-edge technologies often come with a high initial price tag and are seen as drivers of increased healthcare spending. A new therapy, a sophisticated surgical robot.
Right, the sticker shock.
Exactly.
Oh.
And this is the crucial, but the same research that produces those innovations also leads to preventative measures, more effective treatments, and sometimes cures for diseases that used to mean a lifetime of expensive management, disability, or premature death. So these advances ultimately help avert much larger long-term costs.
Can you give examples of that cost aversion?
Sure. Treatments that delay or prevent diabetic retinopathy, that's a complication of diabetes leading to blindness, are estimated to save the U.S. about $1.6 billion annually.
Billion with a B.
Yep. Think of the costs associated with blindness care, lost productivity. Preventing it saves huge amounts. Similarly, programs to prevent type 2 diabetes through lifestyle changes, based on medical research, they can yield significant net savings over time.
So preventing the disease saves more than treating it later.
Precisely. It's that old ounce of prevention idea. And more broadly, public health initiatives, vaccinations, smoking cessation, lead paint removal, all informed by biomedical research, are known to be incredibly cost-effective. Studies suggest every dollar invested in public health saves around $14 in medical and societal costs down the line.
$14 back, okay.
So while the initial investment in a new tech might raise immediate spending, it simultaneously creates this massive long-term cost avoidance and results in a healthier, more productive population. It's a balancing act for policymakers, short-term cost versus long-term savings, but the long-term benefit is pretty clear.
That clarifies the long view really well. Okay, this all sounds incredibly impactful, but putting numbers on it, that seems tough. How do researchers even start to calculate these things? Especially the economic multipliers, like that $2.56 figure. What's the methodology?
That's a great question. It involves some pretty sophisticated economic modeling. A major tool used, especially for assessing the impact of federal funding like NIH's, is the Regional Input-Output Modeling System, or RIMS-2.
RIMS-2.
Yeah, RIMS-2. It's developed and maintained by the U.S. Bureau of Economic Analysis, the BEA, a key federal agency. The basic idea behind RIMS-2 is input-output analysis. It essentially maps how money flows between different sectors of the economy.
Like a web.
Exactly. If you put money into one spot, say biomedical research via an NIH grant, the model estimates how that initial spending ripples through other sectors in a specific region. It then calculates different multipliers to quantify these ripple effects. It breaks them down into three types.
Okay, what are they?
First, you have direct effects. This is the immediate impact of the spending itself. So the salaries paid to the researchers, the lab techs, the admin staff working on that specific NIH grant. Money straight into pockets.
Got it. Direct jobs.
Right. Second are indirect effects. This is the knock-on effect on suppliers. The research institution buys lab equipment, chemicals, software, maybe hires local construction firms to build a new wing. All those purchases stimulate activity in those businesses and their suppliers.
Okay, the supply chain again?
Exactly. And third, you have induced effects. This is even broader. It's the impact of the people who earned money from the direct and indirect effects spending their wages in the local community.
Ah, so the researchers and suppliers spending their paychecks.
Yep. On housing, groceries, restaurants, shops, entertainment. That spending supports other jobs and businesses throughout the local economy.
Apart.
So the analyses by UMR, giving us those multiplier figures, they rely heavily on RIMS too. They use regional tables specific to geographic areas, state, county, even city level. And the model's parameters are updated yearly based on actual spending data. It's quite detailed.
That makes sense for the economic side. But measuring the impact on health and life, that seems even trickier. How do you put a number on extending someone's life or improving its quality? That feels inherently qualitative.
You're right, it is trickier, and it definitely brings in more nuanced considerations, including ethical ones we should touch on. But researchers do have specialized metrics for this. Two big ones are QALYs and dailies.
QALYs and daily, okay.
Let's start with QALYs. It stands for Quality Adjusted Life Year. It's a really common measure in health economics. It tries to combine both the quantity of life lived and its quality into a single number.
Okay, how does that work?
So 1 QLO equals 1 year lived in perfect health. If you live a year, but maybe with a chronic condition that reduces your quality of life, that year might be valued as, say, 0.7 QALYs. The scale goes from 1 for perfect health down to 0 for death.
And how do they decide on that quality number, the 0.7?
That's the tricky part. Researchers use different methods. Sometimes they survey people, asking them to make trade-offs. Would you prefer 10 years in perfect health or 15 years with this specific condition? These choices help assign a utility value or weight to different health states.
I see.
Then you calculate the QALYs gained from a medical intervention. Say, a new drug adds 2 years of life at a quality of 0.8. That's 1.6 QALYs gained. You can then compare the cost of the drug to the QALYs gained to get a cost per QALY figure.
Ah, for cost-effectiveness comparisons.
Exactly. It helps policymakers weigh different options. Then there are Daly's disability-adjusted life years.
Okay, dailies. Different.
Kind of the flip side.
Yeah.
QALYs measure health gained, while Daly's measure healthy life lost due to disability and premature death. It combines years lost to dying early and years lived with a disability into one number representing the burden of a disease.
Got it. Loss instead of gain.
Right. And the NIH actually uses daily data, often from the big global burden of disease study, to help align its research funding with where the biggest health burdens are. It helps them track impact.
Okay. And beyond QALS and dailies.
There's also broader program evaluation and epidemiology. Evaluation research uses scientific methods, like randomized controlled trials, RCTs, to see if an intervention actually worked as intended. And it's important to remember the difference between basic research seeking knowledge for its own sake and applied research, which aims to solve a specific problem. Both are crucial, but basic science is the foundation everything else is built on.
That's a lot of methodology. It's clear they try to quantify this. But like you said, it's complex. There must be real challenges and limitations in getting precise numbers.
Oh, absolutely.
Let's get into those. What about just attributing an outcome back to specific funding, especially with those long time lags you mentioned?
That's probably the biggest hurdle. Directly linking a specific health outcome years later back to a specific grant awarded maybe decades earlier, it's incredibly difficult. That translational pathway is just really long and complex. Take the example of preventing mother-to-child HIV transmission. Cases plummeted in the U.S. between the mid-90s and mid-2000s because research showed antiretrovirals worked.
A huge success.
Absolutely. But that success wasn't due to one grant in, say, 1993. It relied on decades of prior work in virology, immunology, drug development, clinical trials, a whole cumulative body of knowledge built over time. Disentangling the impact of any single piece is almost impossible.
So you can't just draw a straight line.
Rarely. And that leads to the counterfactual problem. What would have happened without that specific funding? We can't really know for sure. Health improvements usually result from many factors interacting. That big drop in heart disease deaths was partly new treatments and drugs from research, yes, but also big changes in behavior like less smoking. How much was due to each? Very hard to say precisely.
Yeah, teasing those apart sounds tough.
And knowledge doesn't flow in neat lines either. It spreads through papers, conferences, informal chats between scientists, market applications. Tracing it back to one specific basic research grant is often impossible. And what's really interesting, even when a clinical trial has negative results, meaning the treatment didn't work, that's still valuable. It tells doctors to stop using something ineffective or harmful. But that benefit, preventing harm, is almost never measured in these return on investment calculations.
That's a great point. Measuring what didn't happen. So beyond attribution, what other methodological snags or data gaps make this hard?
Well, several things. Just defining and measuring health consistently is tough. We often end up relying on mortality rates because getting detailed quality of life data, like for QALYs or dailies, consistently over time for many diseases and populations is just really hard.
The data isn't always there.
Right. Then there's the issue of linking funding to specific diseases. Basic science grants often explore fundamental processes relevant to many conditions, so they don't list just one disease. Even NIH institutes fund research across many areas. Systems like the NIH's RCDC try to categorize things, but it's imperfect. And tracking knowledge flow through citations is one approach, but does the citation always mean real knowledge transfer happened? Maybe, maybe not. Also, funding isn't random. Money often goes to areas with high scientific promise or high public health need already. So if progress happens, was it just the funding, or was it the underlying potential that attracted the funding in the first place? Separating cause and effect is tricky.
Correlation versus causation.
Exactly. And surprisingly, given all the talk about new tech driving up costs, there's actually very little solid research directly linking specific funding patterns to later healthcare cost growth. It's hard to trace basic research effects to specific technologies and then to overall system costs. It's a big data gap. And finally, getting comprehensive, quantifiable impact data from all funders. Other government agencies like AHRQ, big private foundations like Gates can be inconsistent, especially if their focus is global health rather than specifically U.S. biomedical impact. So piecing together the total picture is challenging.
Yeah, so lots of complexities in the measurement itself. Okay, let's turn to maybe the most sensitive part, the ethics.
Hmm.
Using metrics like QALYs sounds efficient for allocating resources, but what are the ethical or societal issues that come up when you try to put a number on quality of life for healthcare decisions?
This is a really critical area because while QALYs aim for objectivity, trying to maximize health gain per dollar spent, they absolutely bring ethical considerations to the forefront. A major one is just the fundamental question of whether you can objectively measure quality of life.
Yeah.
Assigning a single number to a complex health state is inherently subjective. It might not capture what an individual actually values or experiences.
Yeah, reducing a life experience to a decimal point.
Exactly. And then there's the issue that QELI calculations often structurally favor younger people
How so?
because a younger person has more potential years ahead of them to benefit from improved health. So an intervention adding, say, 10 quality-adjusted years might look better in QELI terms if given to a 30-year-old than an 80-year-old, even if the health improvement itself is identical.
Ah, so it can look like ageism.
That's the concern, yes. Potential discrimination based on age. The framework might also not adequately account for existing health disparities between different population groups. Critics also point out it could lead to prioritizing cheaper, less effective treatments if they look better on a cost per QLI basis. And disability advocates argue strongly that QLIs discriminate against people with disabilities.
How does that argument go?
Well, if perfect health is a way, any state with a permanent disability automatically gets assigned a lower value, even if the person leads a full and meaningful life. This can be seen as devaluing their lives or making treatments for them seem less worthwhile in QLI terms.
I can see that.
And patient preferences might not align with maximizing QALYs. Someone might choose a treatment with nasty side effects if it lets them reach a specific life goal, even if it lowers their overall quality score. It's also really hard to compare QALYs across totally different situations, like fertility treatment versus heart surgery. They address such different aspects of life.
So it seems these metrics aren't really value neutral, even if they try to be.
Precisely. They are inherently value-laden, both in how they're constructed and how they're applied. And finally, there's this tension between cost-effectiveness, which QALYs promote, and the rule of rescue.
The rule of rescue.
That powerful human instinct to save an identifiable life in immediate danger, often regardless of cost. Think pulling out all the stops to save one trapped miner. QALYs might suggest those resources could save more statistical lives elsewhere, creating a real ethical conflict.
Yeah.
So QALYs can be a tool, but they need to be used carefully, alongside other considerations and a clear understanding of the values embedded within them.
That's a huge amount to think about. Really underscores the challenges. Okay, so wrapping this all up then. We've seen really overwhelming evidence that investing in biomedical science delivers profound, diverse returns. It goes way beyond the lab, boosting public health, extending lives, stimulating major economic growth across the board.
Absolutely. It's this dual impact that resonates everywhere. Federal funding, especially NIH, is a massive economic engine. Billions generated, hundreds of thousands of jobs, strengthening regional economies, keeping the U.S. competitive. And at the same time, it's fundamentally driving huge improvements in health outcomes. From infectious diseases to heart disease to cancer to the opioid crisis, the fingerprints of this research are everywhere, saving lives and improving quality of life.
Right.
And even though new tech might raise initial costs sometimes, the long-term effect of prevention and better treatments is significant cost diversion and a healthier, more productive society overall.
And we've also dug into the real complexities in measuring all of this, precisely the time lags, the attribution problems, the data gaps, and especially those thorny ethical issues around metrics like QALYs.
Yeah, and it's so important to acknowledge those challenges. But crucially, those measurement difficulties don't negate the clear, consistent, positive impact we see. The returns, however you try to measure them economically, in lives saved, in healthy years gained, are just undeniably substantial. It makes continued strong federal support for biomedical science a strategic necessity.
It's not just another budget line item.
Not at all. It's a foundational commitment to the nation's health, its economy, and, well, its future.
So what does this all mean for you, listening? It means a healthier future is possible. It means a stronger, more innovative economy. And it's really a testament to what sustained scientific inquiry can achieve.
And maybe a final thought to leave with everyone. Given that biomedical progress compounds over the very long term, and given those ethical complexities in just putting a dollar value on health, what other ways, beyond purely economic metrics, should we be thinking about to ensure we keep investing smartly and equitably in this kind of science for generations to come? Something to ponder.